today is action-packed, so we are going to dive in. We'll start out with a quick hello and welcome to Plan4Health, and then an introduction to HIAs, and then 3 case studies from our Plan4Health participants. So some of you might actually be wondering what exactly is Plan4Health, which is a fair question. We know some of you are members of other Plan4Health coalitions. Some of you may be working with the American Heart Association or the National WIC Association on similar projects. But some of you may be brand new to Plan4Health. We wanted to take a moment to tell you a little bit about the project. So in September of 2014, the American Planning Association received a 3-year commitment from the CDC to prevent chronic disease at the community level. In early 2015, APA awarded $2.25 million to 18 coalitions across the country to promote health equity in 2 focus areas: increasing access to healthy food and beverages and increasing access to physical activity opportunities. So at the national level, APA is partnering with the American Public Health Association. So APA is the plan, and the American Public Health Association is the health in Plan4Health. This key partnership at the national level is mirrored at the local levels. So all coalitions in Plan4Health are anchored by APA and APHA members. We also wanted to tell you a little bit about how we think about getting to our vision, how we actually conduct our work. So we have some core values here that are in bold, and today is really about showcasing our member expertise. So we know that as planners and public health professionals, you are out in the community doing this work, and we're really hoping to build a learning network, build local capacity, and create the Plan4Health community. And of course, what introduction to Plan4Health would be complete without showcasing our new website? So if you want to learn more about the project, and I know this has been a very, very quick overview, please check out plan4health.us. There are individual tabs for each coalition. There's also a resource page that's open to the public, to APA members, APHA members, and always some news and upcoming events. And if you are a fan of social media and you happen to be on Twitter, please don't hesitate to use the hashtag Plan4Health and join our conversation. All right, so now that we've got the introduction out of the way and you're all officially members of Team Plan4Health, let's go ahead and dive into the topic of this webinar. So up first, we have an introduction to HIAs by Elizabeth Witten. So Elizabeth Witten is a research associate at the American Planning Association's Planning and Community Health Center. Liz conducts research projects, promotes the work of APA members, and advocates for stronger integration of health and planning professions. Liz's experiences as a Peace Corps member in rural Morocco has led her to pursue career in land use and public health planning. She has a master's degree in planning from Florida State University and a bachelor's degree in business management from the University of Alabama. And Liz will be starting us off today.
Good afternoon, and thank you for joining us today. As Elizabeth said, I'm Elizabeth Witten, a research associate in APA's Planning and Community Health Center. I'm excited to share information about health impact assessments, and in particular, work that APA is doing to better understand the use of HIAs within planning. Let's start by defining what a health impact assessment is, or as they are commonly known, HIAs. The International Association of Impact Assessments defines an HIA as a systematic process that uses an array of data sources and analytic methods and considers input from stakeholders to determine the potential effects of a proposed policy, plan, program, or project on the health of a population and the distribution of those effects within the population. This is a rather lengthy and academic definition. The Health Impact Project will often describe HIAs as a tool that combines scientific data, health expertise, and public input to identify the potential effects of a proposed new law, regulation, project, or program. An HIA will typically follow 6 steps throughout its HIA process. The first stage of an HIA is to assess the feasibility and impact that an HIA would have on a proposed plan, policy, or action. Essentially, we want to know, would an HIA have an effect on the proposed plan, policy, or action as it's currently written or in development? At the scoping stage of an HIA, This is where we define the objectives of the HIA and the process that will be followed throughout the course of the proposed assessment on the plan, policy, or action. And then in the assessment phase, this is where research is conducted to form analysis and the pathways of how the proposed plan, policy, or action will affect health. And oftentimes, this research is qualitative data. In the recommendations phase, we use the analysis from the assessment phase to form recommendations. And then in the reporting phase, we disseminate our findings and recommendations to decision makers, stakeholders, and the general public. Following this dissemination, we have the monitoring and evaluation phase. In this phase, we track the impacts of HIAs on the decision-making process and the decision itself. HIAs can take many forms. We have a desktop HIA, which is a rapid HIA that entails little to no public engagement. A rapid HIA can be completed in just a few weeks or several weeks and usually involves literature reviews and qualitative analysis. An intermediate HIA requires additional resources, involves more complex pathways, more stakeholder engagement, and more detailed analysis, but usually does not include a collection of new primary data. A comprehensive HIA is more detailed and takes more time than an intermediate HIA and often includes primary data collection and can take a year or more to complete. This brings me to APA's project, HIA's Role in Planning. This project is supported from a grant from the Health Impact Project, a collaboration between the Robert Wood Johnson Foundation and the Pew Charitable Trust. Through this project, we want to further the education, training, and development of HIAs as an integral part of planning practice. We aim to achieve our mission through 3 steps: assessing the current state of HIAs in planning, building an HIA toolkit for planners, and then communicating the value of HIAs to planners, decision makers, and elected officials. So we are currently in the assessment phase of this project. We are trying to understand what is the current state of HIAs within planning. And so we began with a research process that started with defining what we meant by planning. And for this project, we have defined planning as the plans, policies, and actions that govern how the built environment impacts an entire population in a specified geographic area. Next, we began to identify every HIA that met this definition. We used existing databases, such as the Health Impact Project database and the UCLA HIA Clearinghouse. Then we read journal articles and reports, and then conducted outreach to partners to find every planning-related HIA that met this definition. We are conducting a summary analysis of all of these planning-related HIAs, and then we have selected a subset for further review in our literature review and case study phases. So what exactly is the summary analysis, and what is this big picture of planning-related HIAs? So to date, 134 planning HIAs have been conducted. This represents 1/3 of all HIAs conducted or in progress in the United States. More than 50% of these HIAs have been conducted on a plan, 1/4 have been conducted on a policy, and 13% have been conducted on a project action, which looks at a specific moment in time of a policy or planning process. And they cover a whole range of planning topics, with land use being an overwhelming majority of these HIAs. And so what have these HIAs told us so far? Well, there has been tremendous growth in the field of HIAs. So our analysis starts in 2004, and it grew a little bit until 2008, and then the trajectory has skyrocketed with tremendous growth between 2010 and 2012. We have data that indicates that the field is leveling off a little bit, and we've realized that no two HIAs are alike, and the way HIAs are conducted can have differing impacts in different contexts. And with 14 different planning topics covered in this 134 master list, we realize that HIAs are representative of planning's holistic nature. So what's next for assessing the current state of HIAs within planning? Well, we are currently in the literature review and case studies phases. We have selected 28 for further analysis. This 28 is representative of our master list with oversampling for areas of plans and policies that represent development regulations, public finance, infrastructure, climate change, and climate change. We have 23 selected for the literature review and then 5 for the case study analysis. And the case study analysis is differentiated by geographic location, decision level, and planning topic. All of this information will be released in a full report in fall of 2015. If anyone is interested, we have released a preliminary analysis of the 134 planning HIAs. It is available on the Planning and Community Health Center's website. And so how will we use this information? Well, it will inform phases 2 and 3 of this entire project. Phase 2 is to frame and build a toolkit that will assist planners with conducting HIAs. And then phase 3 is for us to better understand how HIAs can influence planning and to assess the value of conducting HIAs on proposed plans or planning-related policies or actions. And we will use this information to figure out the best way to communicate the value of HIAs for decision makers, elected officials, and the general public. And with that, I will turn it back over to Elizabeth.
Great. Thank you, Liz. It's nothing like having a walking HIA library in the office. We really appreciate all that Liz does and brings to the conversation. So that gave us a general overview of the definitions of HIAs and kind of the general plan of a project. But our next few case studies will really dive into some details and share some experiences from the ground. So up next, we have Sandra Cummings. And Sandy has worked for the Marion County Public Health Department in Indianapolis for more than 20 years. In her capacity as a chronic disease department head, Sandy has overseen the development and subsequent maintenance of a wide range of chronic disease prevention and control interventions related to tobacco control, diabetes self-management training, school wellness, cardiovascular screening and education, and general community health. Sandy has worked to increase the capacity of her agency to conduct health impact assessment activities, and she supports the organizational development of multiple community coalitions, including Health by Design, a funded partner in the American Planning Association's Plan4Health project. So Sandy, I will hand this over to you. Oh, and I think you might be on mute, Sandy, so if you wouldn't mind hitting *6.
Can you hear me?
Yes.
Okay, sorry about that. All right, well, thank you, Elizabeth. We were asked to consider doing a HIA by the City of Indianapolis' Division of Economic Development, which is heavily involved in redevelopment activities in this particular area of Indianapolis that I am going to refer to as the Meadows. This health impact assessment was the first formal HIA conducted here in Indianapolis, the first one that was actually a distinct standalone project, not just our usual work in trying to encourage different sectors to include health considerations in their work. The aims of the project were to conduct a health impact assessment on developing a grocery store within this food desert in Indianapolis, and equally as important really was just building the capacity within our own agency to do HIA. Also worked with the Indiana University Fairbanks School of Public Health to carry out this work, as well as the Meadows community. So the Meadows is on the northeast side of Indianapolis. It's an economically depressed area, has been for several decades. It's a very high crime area. It's a food desert. There's a plethora of fast food. But the good news is that it's been undergoing redevelopment for about 4 years. So the screening process for this particular project was done in a relatively informal way, largely by being aware of the economic development activity that's been going on here, knowing that this is a food desert, and being aware of a coalition of people specifically working on food access issues for this area and the far east side of Indianapolis called the Indy East Food Desert Coalition. The health department's headquarters building is actually in this neighborhood as well. But the real key, as I mentioned, was that the Division of Economic Development asked us to consider doing an HIA on the installation of a grocery store. HIAs are done primarily to inform decision-making, so obviously we were real motivated to do the project. And through this sort of informal process, we knew that this would be a useful project for us to get involved in. So to prepare the scope of the HIA, which is the second phase, and that's essentially determining what questions should be answered through the HIA process, we conducted 8 key informant interviews in the first month or so with leaders in the community and other stakeholders. We attended several neighborhood association meetings to talk with residents about their own perspectives of their food environment. And of course, then we met with that Indy East Food Desert Coalition that I mentioned. Then in addition to those sorts of meetings, we convened a formal stakeholder meeting where we talked more thoroughly about what a HIA is, how it's conducted, how its recommendations are created, and how they can be used. That process took about 8 weeks. And that yielded study questions that are here on your screen. So was there reasonable access to healthy food in the meadows? Do community residents believe that they have reasonable access to food? What's the current health status of the population? Is there a relationship between the availability of healthy foods and actual health outcomes? And is there a relationship between access to healthy foods and actually eating it? Then we move to the assessment phase, which is basically the meat and potatoes of a HIA, and this portion of our work took about 4 months. We conducted a literature review, we did do primary data collection, and we compiled a community health profile. So the literature review was conducted by a research assistant who served on our team. We were very thankful for. She prepared it into an annotated bibliography. Many HIA rely heavily on the literature review. After all, what HIA is doing is bridging health information into other sectors. So infusing the health literature into the process, I think, is valuable in and of itself. Quite a few different organizations and individuals have asked for the literature review, so while it might seem like a cursory exercise, it really does bring useful information into the relationships that are being built between public health and planning or other sectors for that matter. So I'm obviously not going to expand on any of the findings during this 10 minutes, but we'd certainly be happy to share that annotated bibliography if anyone is interested. The one issue that I would point out, though, is the importance of bringing economic benchmarks into the discussion whenever that is possible. There is retail food in the meadows. It's largely through convenience stores and Dollar Generals and gas stations and that sort of an outlet. So to describe the food that's available in the area, we visited all of these stores and we assessed their offerings using the Nutrition Environment Measurement Survey, or NEMS, which looks at the presence of 30 commonly sold healthy foods. This tool is one of a set of tools that's put out by the University of Pennsylvania, and we use it frequently in public health and used by others as well to assess nutrition environments. We looked at all of the stores that were located within a 1-mile radius of the proposed grocery store site, and that was 11 sites. So then over the course of 8 weeks or so, we also talked with 344 neighborhood residents. We asked them where they currently shop for food. We asked them what sorts of foods they purchase and how much they spend and how frequently they eat out. We did the surveying outside of a Walgreens with their permission, of course. We did it at a school parent night. We visited with neighborhood associations during their standing meetings. We went to the Adult Education Center in this community, and we also spent time at the public library. He, I think, was offering a $5 gift card for people to complete the survey. It took about maybe 5 minutes to complete it. So then we also developed a health profile of common nutrition-related chronic diseases in the Meadows as compared to our county, Marion County, as a whole. And this is a contribution that I think should routinely be expected from the local health department. If nothing else, we should be providing data. So you can see that the resident population in the Meadows is hospitalized at greater rates than the county as a whole for diabetes, for hypertension, heart disease, and stroke. And they also go to the emergency room more often for these conditions than the county as a whole. We pulled out mortality data as well, and you can see that people in the Meadows are dying at higher rates from these conditions. So obviously this is a community that suffers disproportionately from these leading causes of morbidity and mortality. Taking assessment data and molding it into recommendations is the next and probably the most important step. We convened another stakeholder meeting to present all of the assessment data and information, and then led a discussion that resulted in these recommendations. Most of the recommendations that we offered came directly from neighbors. People obviously know what's best, what they need and what will flourish in their own communities. We got a lot of feedback, as you can see, not just on groceries, but on eating, on nutrition, on cooking. Much of this feedback has led to some other resource development that's distinct from the actual physical store that we've been talking about. And reporting back to the community and anyone that's interested in the findings does take time and resources, so I would just say it's really important during the entire project to keep very good notes and documentation so that the reporting sort of just falls together easily. We created an executive summary and then a much more extensive report, and we tried to get one or both of those into the hands of everyone we talked to throughout the process so that it could be used by them in whatever ways they saw fit. And these are some of the examples on your screen of ways that we presented out the information. And the last step in an HIA is monitoring and evaluation. One lesson that we learned about reporting and monitoring is to build in time and resources to do this well and to do it fully. I actually think that a good HIA should result in institutional change that assures that monitoring becomes sort of standard operating procedure. That really did not happen with our HIA. However, we did make 3 different attempts to talk to stakeholders. Our project concluded to ask about its usefulness, and we definitely know that it has been used quite a bit. And I would say that the best news, and in conclusion, I would just share that the city is currently processing a financial package to assist a developer in the construction of a grocery-anchored shopping center at the site, and that the tenants will include a supermarket. And so with that, Elizabeth, I'll turn it back to you.
Great. Thank you, Sandy. That was fabulous. Oh, and I'm going to leave your contact information up if you don't mind for a second. That was fabulous and very helpful to start to see how do we actually put this framework into action. And very good advice about keeping track of all the notes and findings so the report comes together easily. That is always our hope at the end of a project. So I'm going to shift now to Alex C. Smith. And one second, Alex, let me just pull up your slide. I know you've got a lot of fantastic graphics, so our system might be struggling to load it. There it is. So Alex C. Smith is the program manager for the Plan4Health grant at the Columbus Public Health, in Columbus, Ohio. Alex has previously coordinated a large district school travel plan and an HIA on the travel plan. Alex has a master's in city and regional planning with a focus on non-motorized transportation and GIS, hence the wonderful graphics. Alex has also worked in active transportation advocacy previous to his position at Columbus Public Health, and Alex co-founded a neighborhood advocacy group that is establishing and promoting a bicycle boulevard system in Clintonville, Ohio. So welcome, Alex. I'll hand it over to you.
Okay, thank you. Can you hear me?
Yes.
All right. So that was a wonderful introduction, so I won't go repeat any of that. But what I'm here to talk to you today is about the Safe Routes to School health impact assessment that we completed earlier this year, and then talk a little bit about how our HIA program here at Columbus Public Health developed. So with that, we'll move on to this required slide here, which I won't spend too much time on, but I'm happy to talk about public health at length at any point in time. And here at Columbus Public Health, we protect health and improve lives. So moving on to the content here, rapid to comprehensive HIAs. So our HIA program here at Public Health came out of our Healthy Places section, and the Healthy Places coordinator at that time that really took a big lead on doing health impact assessments at Columbus Public Health, which started with a health impact assessment on the Northeast area plan here in Columbus, Ohio. This was, again, a rapid HIA, couple pages, looked at 6 key elements through the Northeast area plan. We've really focused on BMI, physical activity rates, and chronic disease, looking at the demographic data, and then PA ended up being the main health impact that was studied, and more specifically the impact of the built environment on physical activity. Some of the recommendations that came out of that were a mixed-use center for the area, some lower density housing on the peripheral, while a little bit higher density towards the mixed-use center, and then really just looking at how you could connect jobs, places of shopping, places of learning, places of play to the center through an interconnected system of greenways or trails or even on-street facilities for bicycles and pedestrians. Then 2010, after doing some other rapid HIAs in between, they developed more of a checklist kind of style to formalize it a little bit. So looking at screening criteria, basically what this was to give to other departments so that they could bring awareness to the decisions that they're making with plans, policies, processes that may contribute to health that may not be thought of otherwise, and to highlight some of the healthy features in these project decisions as well. And it's also during that time that we developed an HIA intro sheet to really introduce people to what an HIA is. And then looking at the built environment, cultural considerations, employment effects on natural resources, all those things played into this development checklist, but it was mainly focused on the Department of Development. Then in 2011, there was a pilot project where we looked at a few different, again, site area plans and site plans as well. So making sure that these buildings, these sites, or these areas that are being developed were conducive to physical activity. What came out of this was are the site plan reviews that we do here at Public Health. The Healthy Places Coordinator, Scott Arch, is the person that is charged with that. So anytime we have any major variances or any kind of sites that are being redeveloped, the site plans go to Scott, and he reviews them to make sure there is access to and from the site for active transportation, but also at the terminus, making sure there's things like bike parking and where the bike parking is placed, that's placed near the entrance and such like that. So, what came out of all this was more formalized than what we do now. And then in 2013, we started to look at some of the future goals for HIAs at Columbus Public Health. One of the things that came out of that were a comprehensive HIA, the desire to do a comprehensive HIA. And around that same time, there was a funding opportunity from the Ohio Department of Transportation for Safe Routes to School projects involving the large district school travel plans that Elizabeth mentioned briefly earlier. What these travel plans are essentially are for large urban districts where ODOT had not been receiving requests for funding at a rate proportionate to their population representation in the state. So basically a lot of funding was going to rural areas or suburban areas because of the places that were applying. So the idea behind this is to get more urban areas, to get a plan that covers all these urban areas and to really capture a lot of schools, the whole district, at the same time. And at the same time that funding became available, we found some funding to do the Safe Routes to School HIA on that large district school travel plan. And now we are currently working on a health impact assessment on the Connect Columbus plan, which is a multimodal thoroughfare plan that will define transportation in Columbus for the next 20 years or so. So back to the Safe Routes Plan. So this process worked much like many HIAs do. Some interesting things that came about it. Again, this was on a travel plan that was looking at the whole, all K-8 schools in the entire districts. There are 94 schools, and we needed to pick about 15 focus schools to really have a deeper touch in. So we go do walk audits, we work with the staff a little bit more deeply, et cetera, et cetera. So to find these 15 focus schools, the first lens that we looked through, we took socio-demographic data, health data, and school performance data to find the schools that had the most need, so that when we were focusing on these schools, that we felt we could have a large impact on these schools because they both had the need, and they also had a decent amount of walkers already, or at least the potential to have those walkers there. So the HIA really was very valuable in the fact that it got us down to those 15 focus schools. Then when we moved to the literature review, we decided to look at physical activity, crime and traffic safety, and the effect that would have on safe routes to school or vice versa. But I think the really key thing here is that we had two different steering committees. We had one for the HIA and one for the large district school travel plan. And so having these two committees, and I coordinated both of those, we were able to really share all of the data that we were gathering from that first lens we looked through, the socio-demographic data, into the literature review, into the first-hand data gathering where we used some surveys and et cetera. But at each step of the way, we were able to inform the travel plan steering committee, so the consultant and the whole steering committee were informed in real time, essentially. So they didn't have to wait for us to really put together our analysis into a formal report and report it out. We could do it still formally, but in a meeting setting where we could move a little bit faster with it. So in the sense, there were some of us that were kind of double agents, including myself, that both sat on both steering committees and participated in both steering committees. So again, I really think that was the really valuable thing, that we got to share that information so quickly, and it really had an impact not just on the plan at the end, but on the plan as it was being formed. And something interesting that came out of this too, I mentioned the surveys a little bit and the walk audits that we did. So the walk audits we performed at each of those 15 focus schools. In the mornings, we were doing more of the typical travel plan walk audits, more safe routes to school, what has been done before. But in the afternoons, we engaged parents with a set of 3 questions, which you'll see in the lower right corner there, some of the answers, percentages to those questions, and then a map. And the questions were basically asking, how does your child get to school? Why do they get to school this way? And if they don't already bike or walk, what could we do to change that? And then the maps, the parents would mark the route that their child travels to school. And then what we tried to get them to do is show us areas where they felt unsafe. And we really wanted to separate out crime and traffic safety, and where you felt unsafe from crime or where you felt unsafe for traffic safety, but people just generally marked down where they felt generally unsafe. And so that's what you see here as an example of one of our schools, one of our focus schools. As the areas get darker, move toward from yellow to red, is where there was a higher percentage of agreement amongst parents as where that place is unsafe. And what we're going to do with this is take this firsthand data gathering that we did and compare it with the actual crime data and put those things together to see what the perception of crime was and what actual crime or traffic safety was out there. Unfortunately, we didn't get enough respondents for some of these surveys at most of these schools, and then the crime data set came in a little bit late too, so it caused us to not really be able to do as robust of an analysis as we would have liked. But I think this idea of perception mapping, which is also called fear mapping, and we worked with a professor from Kent State University who came up with this methodology, Dr. Jacqueline Mills. I think it could be very valuable to future HIAs in different aspects. And another, of course, the connections that we made here were very valuable. We connected, both within city departments with public service, which led, Scott, who I mentioned was the Healthy Places Coordinator, is now the Bicycle Coordinator and sits on various subcommittees as well involving bicycling and pedestrian initiatives with the city. I also sit on some subcommittees as well. So it really established that relationship and gave us basically a seat at the table, and not only a seat at the table, but maybe like a bigger seat at the head of the table in some cases, I guess. So we really have a good influence on how some of these decisions are made. Also with the community groups, when we did the walk audits, I did a lot of outreach from area commissions down to neighborhood block watches, and that gave us connections within the community and made me more aware of where those community groups are and what exists. then with the school administration, I was able to present to all of the administrators, all of the principals, I should say, at a monthly meeting, which for an outside entity to be able to come into their monthly meeting was, pretty much unheard of before that time. So making those right connections with the right administrators to get me in front of all those folks, and they all knew who I was when I contacted them later, that was also very valuable, and valuable for our implementation and our future research, which we're looking at now, again, the Connect Columbus plan, the multimodal thoroughfare plan. We're also looking at tailpipe pollution and food access along with physical activity and looking at crime as well with that. Also integrating safe routes into the wellness policy. I think the health impact assessment really solidified what the plan was because we had so much research to back what we were saying, the recommendations that we were making, and the predictions that we were making, and that helped us get Safe Routes to School integrated as something that should not only be allowed but promoted within the district through the wellness policy. And now working with capital improvements within the school district as well. I recently met with one of their project managers about a school that is located on a bicycle boulevard but does not have any bicycle parking for the students at the high school. And even though that's outside my realm, I mainly focus on K-8 schools. I nevertheless took the chance to see if we can try to figure out how we can do that even though they might not have funding for that. So again, just all these relationships that were really built out of this, I think, extremely valuable. And that's all I have for you today. I could talk a lot longer about it, and I'm happy to answer any questions. But for now, that's what I'll say.
Great. Thank you, Alex. That was a fantastic presentation, and I know I attended the HIA National Conference where you shared a little bit about the perception mapping and fear mapping, but it's still so fascinating, and I really enjoyed hearing it again. And of course, the theme of building community partnerships and relationships is definitely coming through, and I think will be continued in this next part of the presentation. So I want to introduce Barry Keppard. He's currently the manager of the Public Health Division at the Metropolitan Area Planning Council, MAPC, in Metro Boston, Massachusetts. Previously, Barry was a senior regional planner with MAPC and led work for the implementation of the Metro Future Plan through a combination of public health, land use, environmental, and transportation planning projects. Barry supervises and provides technical assistance on projects that support efforts to increase the accessibility and affordability of healthful foods and the adoption of comprehensive community design approaches to enhance walking, bicycling, and active transportation. Barry also manages the division's health impact assessment practice, which aims to strengthen the connection between physical and environmental factors in health and to look at how policies and programs could address health inequities. And of course, Barry is a member of the Plan4Health Coalition in the Metro Boston region. So I will hand things over to you, Barry.
Pardon me. Thanks, Elizabeth. And it's a pleasure to be here, and thanks for the opportunity to be here. For those on the call, I'm hoping that by the end of this, I can get my voice right, you'll see a bit about how we're kind of transforming our community engagement work through doing health impact assessments, how we're essentially kind of putting that into practice, and ultimately how this process of doing health impact assessments is leading us not only from HIAs, but even more broadly to a health and all policies practice. And, oops, sorry, hitting the wrong button. There we go. But ultimately what you'll see is I'm the beaker in this process, and in many ways health impact assessments have been our Bunsen honeydew. And what we're trying to think more and more about and purposely think about is the people in the thing, not just the process itself. Sometimes we can get caught up thinking about the process, but thinking more and more what this means for the people who are involved and the people that ultimately be affected by the decision that we're looking at. In the past, typically, I think as a planning agency, we would go about community engagement in a way where we'd invite people to where we are, ask them to talk about the things that we want to talk about. I think we gave them a meaningful amount of time to process lots of information and come up with decisions, and then report out right away. And it was something that I think we did and thought we were successful at as an agency. But as we kind of got into it, and as I think more about this as I look through the health impact lens, it was a process essentially where we'd kind of surface in a way, ask some questions, disappear while we're doing some work, and for large periods of time absolutely be absent, and then come back with large pieces of information and questions for decision making that we'd ask people to hurry up and get to right away and not be able to do in kind of a sufficient amount of time. And so that's something that I began to think about a lot, and the team here began to think about. And what we found from that is often that I think maybe as others in their experience that people might not stay engaged with this. with the process and what we're doing, that often the choices that people had were very kind of either binary or not very, or very limited. Who we had in the room wasn't maybe who we were looking for. We'd also be looking at issues maybe through a lens where we weren't taking into account of a lot of the other surrounding and contextual factors. And often I think we didn't leave people as empowered and coming out of those meetings in a way that we would like. And through the health impact assessment process, I think we've been able to get more at this issue of whether or not we're pushing this and trying to push a process versus whether or not that process is actually being asked for and requested. And not only that, are we doing the process in a way that kind of speaks to not only those people that are affected, but to the idea is, are we leading to efficacy, whether it be at the individual or community level? And then lastly, are we doing the process, and this is where the health impact assessment I think has been really wonderful for us, is to guide us more into the feelings of not only sympathy of looking essentially where a person's situation might be, but to think about if we were in that situation, what would it be like, and thinking about how we can be more empathetic about our work. And so really the confluence of that past experience and those perspectives have kind of led us through the health impact assessment process to really transform what we're doing through our community engagement. And as a planner, I think it's, for me, being pulled more and more into the public health model of engagement and thinking about where these two areas fuse and how we can really make that evolution from not only doing engagement in the health impact process, but bringing health into more planning processes here at MAPC. One thing I guess I want to speak to that's been really transformative in that aspect, and I think both Sandy and Alex referred to, is just the scoping process itself, coming into a piece of work and not only coming in with a specific set of things that you're going to look at, but coming in with a topic and thinking about what does this topic mean, how do the people who could be affected and ourselves think about how health figures into it, and having a real conversation around that and some prioritization around that. And it's been a very, very different experience, pardon me, to do that rather than essentially coming in with kind of a predefined conversation that you want to have. I think another thing that's really helped as we've gone through the health impact process, and this reflects that we've been fortunate enough to do around 7 or 8 health impact assessments, is that we actually did a quality improvement process looking at the HIAs that we've done. And for those on the public health side of things that have done that, it's a very, very empowering and sobering experience to understand where you're successful, where you've engaged people in the right way, and where there are opportunities for improvements. And I think without the HIA model and without the public health model, we may not have done that as much in our work, and I think it's really been important, and we've actively shifted what we've done through some of our current HIAs, which will be reflected a little bit later in the presentation. And I think also I've been lucky enough to be in an environment where we thought a lot more about what it means from the perspective of equity. Are we being just, and are we kind of taking into account not only the situation itself, but who may benefit, who may not benefit? When we look decisions come in around housing, for example, or new development, thinking more about not only those that will benefit, but those that won't benefit, and issues like displacement, again, that we necessarily didn't think about when we talked about issues of smart growth and development, and giving more thought to essentially who gets to stay there and who's kept an area thriving in the past up to the present before the change occurred. Some of the things that we're also taking into account in our work is that idea that you or I or others might do some of this work on a daily basis. So coming into a conversation and situation can be very easy, or at least a little more easy to pick up. Whereas if we're working with residents who are working 2 jobs, who might come from backgrounds that are more difficult, and this isn't part of their everyday, how do we get them into a process and engage them in a process that actually warms them up? And so beginning from a point of how do we kind of warm up to a conversation rather than jumping right in, and that's been a very, very important part of what we're doing and how we're having conversations and what we're gaining from those conversations. I think as reflected in Sandy and Alex's presentation as well too, thinking less and less about where we hold the meeting, but where we meet people. And sometimes that may mean a room, or that might mean a meeting space, but more and more I think it means less of that. And especially in the health impact assessment process, how do we kind of get out of the particular place, and maybe scoping or something else becomes a placeless thing and occurs where people are and through the conversations that we have with those people. And I think a big part of, again, is kind of meeting people where they are now, less and less calling people and kind of asking them to come to us, going to them, to having those conversations. And through the health impact assessment process, it's also been a way of us kind of figuring out where their coalitions mobilize and engage on particular topics, and where health may not necessarily be part of that conversation yet. And how do we go out and have those conversations in advance and lead to the work and bringing health into conversations where it isn't present? And so I feel like more and more through the health impact assessment process, we've been able to kind of modify how we do our work. And so when we come to the surface, we're much more clear about when we're going to be there. If we go away to do work, we're much more clear and short term about when we come back. And then we provide more time at the end to really have those conversations as we finish each step of the health impact assessment process. And I think ultimately what this work is doing is it's actually kind of influencing us as a planning agency to move from health impact assessments as a tool where there may not be a health in the conversation yet to those places where health has begun to be introduced into the conversation. So we talked about land use and grocery stores, and we talked about the transportation piece of it. From Liz's presentation earlier, we heard about housing and climate change, and is thinking maybe less and less about doing a formal HIA, but what does it mean to bring a health lens and a health and all policies perspective to the work that we're doing. And we're doing that here, at least at MAPC, by bringing into our housing work, or bringing into our environmental work, little by little from the lessons we learned from our HIAs, but also a lot of the great HIAs that have been done in the planning field already. And so just a couple quick examples of the way that we're doing that. Right now we're doing a health impact assessment of a small business technical assistance program and looking at where are the health implications of providing technical assistance and financial support or access to financial capital for small businesses, those essentially from lower income background or disadvantaged areas. And so rather than essentially hold the stakeholder scoping session, we integrated our scoping session into their biannual meeting around what they're doing, what the program requirements are. And so part of it was our conversation, but part of it was also participating in their conversation and listening passively to the issues and things that are focused on. Another way that we're doing it, in which we're kind of changing it, is kind of building a longer term relationship with some of the other stakeholder organizations in our area, especially those in the community. So a growing movement in Massachusetts is community health workers. And the Community Health Education Center here in Boston trains and works with community health workers, both for everyday practice, but also for certification. And what we're doing now is beginning to think about how can we talk to them and have conversations not only about individual care and self-management, but what can we do to think about the communities that they serve and how they can think about the health impact assessment or health and all policies model to connect to their work, both they themselves, but also the resources that are available to them. And then lastly, I think one of the most exciting pieces for us right now is that we're trying to bring a previous health impact assessment model that we did called the Healthy Neighborhood Equity Fund, HIA, and build it into another transit-oriented development process. So just north of the city of Boston is the city of Chelsea, which is about to receive the extension of a bus rapid transit line. And so we've begun to integrate health into that process, working with our housing planners, our economic development planners, our community liaisons that are part of that project. And rather than having the HIAs be as a standalone item, it's actually being integrated into each piece of that process so that it's going to influence not only the external decision-making for the city of Chelsea, but also the agency's internal decision-making. So it's both kind of an internal and external health and all policies model that we're looking to push forward. And so I think ultimately for us, what this reflects is the statement that essentially where health begins and where we think is responsible for a majority of our health is actually in the places that we live, work, learn, play, and gather. And so these is a process, again, that health impact assessment, I think, has helped us think about as a bridge and moving us from those places where we weren't having health as a conversation to now having health as part of that conversation. And again, moving it from essentially a side conversation into the main conversation. And so just wanted to offer again that this is essentially something that we're learning, and it's something that's clearly an evolution. But it's great to see this transformation internally and with our own work and to have the opportunity to do it. So I'll stay there and say thanks again for the opportunity and look forward to the questions.
Great, thank you, Barry. It's fabulous that HIAs have continued and are becoming fully integrated in your work, and certainly I think that final slide mirrors the vision of Plan4Health in many respects as we think about the full integration of planning and public health, our way of work and play. We just wanted to put out a call for questions. If you haven't had a chance to chat them in, feel free to do that now. We've received a couple, and we're going to go ahead and respond to those. But first, I wanted to share a slide that Liz put together about general resources for HIAs. And would you mind walking us through the slide, Liz?
Sure. So there's a couple of just general about health impact assessments that you might find useful. One is an online course that APA, in association with the National Association of County and City Health Officials, developed. This is an online course that's available on both APA's website, the NHA's website, as well as the link in this presentation, which will also be available on the Plan4Health website. This 6-hour course is really great for getting a how-to guide of how to conduct an HIA, and this course has been sponsored by the Centers for Disease Control and Prevention. NHA also has an entire health impact assessment resources page that can be very useful. Human Impact Partners has a tools and resources page as well, as does the Health Impact Project. And many of the resources on all of these pages could help you with conducting an HIA in your city or region.
Great, thank you. So one of our initial questions focused on how an HIA could be used for planning in the city, county, or First Nation. Oops, I'm sorry, it's hard to read the full question here. One moment. And it sounds like this planner is thinking about really diving into the HIAs and working with a particular community on the Navajo Nation. And I'm just wondering if you have any thoughts about that, Liz, for any particular resources or tools, and then we can open it up to Alex, Barry, or Sandy if they have any experiences they'd like to share.
Well, first of all, as I'm sure the person asking the question knows, is that the tribal plans carry with them their own specific set of requirements as required by their funder and their tribal government. So they do have to consider that context. But there have been a couple of HIAs on comprehensive plans that they could use as a resource and as an example. So immediately coming to mind is an HIA done on the Humboldt County Comprehensive Plan. This is a rural area in Northern California that might be useful. And several other county-wide comprehensive plan HIAs have used the Humboldt County HIA as an example and use that to inform their HIA process. So that those might be some other resources. APA has a tribal planning interest group that might also be able to provide specific information as it relates to the Navajo Nation and projects that have been going on around in that area. If you send me an email, I'm happy to connect you with the interest group as well as connect you with more specific examples of HIAs that you might find useful.
Great, thank you, Liz. I will chat your email out to the group if that's okay. Mm-hmm. And then we do have a couple of other questions that are coming in. And I know you just touched on this when you were just speaking now, Liz, but do you have any other examples, or have you found HIA useful for planning policy and projects in really rural areas, so such as cities with populations of under 5,000? And this question has a specific mention of safe routes to school as well. So maybe, would you mind starting, Liz, and then we'll open it up to Alex and Barry and Sandy?
That's a great question. So I'm trying to think of an HIA down in a very rural area with a population of less than 5,000, and at the moment I'm drawing a little bit of a blank. There have been HIAs conducted on safe routes to schools like Alex talked about, and so that might be a really good resource, and then think about how you can apply some of the stuff that Alex talked about into a more rural context. Mm-hmm. And that would be my first inclination. As I think about some rural HIAs, there's very few in our analysis, and they're all much broader areas so that they have a larger population than 5,000 people. Mm-hmm. But if you contact me, I'm happy to reach out to APA members and partners to find out more information that you could find useful in your job. And with that, I would open it up to the rest of the presenters to see if they have anything to add.
Yeah, this is Alex here. Yeah, I haven't, as far as rural HIAs, I know there are definitely some out there. Not that I'm aware of with safe routes to school. The HIA that we conducted here, I think, could have some applicability to what you're looking at, being that we looked really at 15 schools, not the whole 94 schools with the HIA. So it was kind of like a smaller area in a sense. Obviously, there's different issues that are going to come into play. But yes, you can. We will have the HIA on our website here soon. I'm still working with communications to get that on the website. So at Columbus Public Health, you can look for that within the next couple weeks. Then it'll be on our website. And feel free to contact me with any questions that you have more specifically.
Great. Thank you so much, Alex and Liz. And we do have one more question, it looks like, and this is a pretty specific question for you, Sandy. Just wondering about how the HIA was financially supported. So did the city pay for the HIA, and if not, who did? And then what was the cost for conducting the project? Would you mind responding to that?
Sure, I'd be happy to. This project, we actually had to seek a grant. We really don't have staff that are dedicated to HIA, so we're just trying to build our capacity, and so we were fortunate that the Indiana Minority Health Coalition awarded us a $18,000 grant to carry out this 6-month project. And we used those funds, we used about a third of them to pay for the epidemiologist that did the health profile, dug into those data, and then synthesized and interpreted it and wrote that portion of the report. We spent a fair amount of the money for the research assistance time to do the neighborhood food retail environment measurement, so going into the stores, and also for surveyors, which were public health students, graduate students. We trained them and deployed them with ourselves to go out and meet with the folks in the neighborhoods. That's super labor intensive, so we were glad to have the dollars to do that. And then we also bought that $5 gift card, so we spent like $1,800 or so on that. So, you know, this wasn't part of our operating budget. We were able to get a grant. If we carried it out on our own, obviously we would have had to scale back some of that work. But on the other hand, partnerships with coalitions and academic centers would probably yield some boots on the ground for the kind of surveying that we did. It might just be a little harder to dig them up. So I hope that answers the question.
Great, thank you. Alex or Barry, do you want to make any comments about how your HIAs are supported? I know they were woven into your presentations, but any advice for folks who are looking to fund an HIA?
This is Barry. I know for us primarily it's been outside funding, although our very first HIA was internally funding around, there was a very rapid HIA, and so I think at least the trend still seems to be that it's essentially seeking outside funding. So the two thoughts I would offer on that moving forward is thinking about how more we could get that integrated into existing project budgets, which is, I guess, always a struggle when people are used to doing a project a particular way. I think the other piece is thinking about as the various entities, whether it be hospitals or health boards, do health needs assessments, I think there's the opportunity to influence that process to be more like a health impact assessment. And so that's another way, I think, of potentially modifying a process to kind of inform or at least get the basis for informing other decisions from a health perspective.
And yeah, Alex here. Yeah, we have also, it's outside funding. Again, the same as Barry said, besides our rapid or checklist HIAs, the comprehensive have been received outside funding to either fund them or partially fund them. We could say that we do kind of an in-kind donation, and that our epidemiology department donates an epidemiologist that takes a percentage of their time to work both on the Safe Routes HIA and the Connect Columbus HIA as well. But besides that, yeah, it is a bit of a struggle sometimes to get the funding, but really the health in all policies is, why we're moving towards that to really integrate into what's being done every day.
Great, thank you both. Well, I think we are just coming up to 4:30, so we will conclude the presentation here, and I want to thank our speakers today. It was fabulous, and of course, all of you for attending. We really appreciate your time. And as our final closing slide, we just want to remind you about the Plan4Health website. A recording of this webinar will be available on the events page, in the next couple of days. And if you have any questions or concerns, I will go ahead and chat my email address as well, and you're welcome to contact me. Thank you so much.
Thank you.
Thank you.